Thank you very much for this invitation to speak. I'm very honoured and privileged to speak to you. Just a quick message to the person who pressed the ejector seat. It didn't hurt, and I'm back. So what I'd like to talk about is our management of fungal keratitis. So we're not advancing the slide here. There we go. So first of all fungi are not the same. This is just a brief diagram to show the different, or 5 different types of fungus. This one here causes athlete's foot. This one causes mucormycosis. The ones we're interested in are the yeasts here and the filamentary fungus here. And so clinical appearances can be suggestive of diagnosis. Aspergillus fungus here in a farmer with satellite lesions, pigmented lesion here with demataceous fungus, and this more diffuse yeast infection on the right-hand side. First of all, how do we make the diagnosis? And so there are signs which can be helpful, and looking at the risk factors and the clinical appearance can alert the clinician. And so contact lens, 10 years ago contact lens would be down the bottom, but contact lens is right up on the top now as a potential risk factor. The chronic use of topical steroid, agricultural injury, chronic ocular surface disease, and travel to foreign climates, or people traveling from foreign climates to your country. A rough breakdown here to yeast infections and mold. Mold is a filamentary fungus, and so more mold in tropical regions, trauma, agriculture, and males. And so your type case for a filamentary fungus would be a male working in a sugarcane plantation or in India, so that type of scenario. The chronic temperate ocular surface disease, previous surgery, transplantation, chronic use of steroid, risk factors for yeast infection. However, this is modified by urbanization, and so developed countries in more equatorial regions tend to have the pattern of yeast rather than mold. I've mentioned this several times today, how important it is just to bear in mind the epidemiological aspect of this, in that what you hear today you may not necessarily be able to transpose if you visit another country, and the spectrum of infection may be dramatically different. Not only gram-positives versus gram-negatives, but the likelihood of any corneal ulcer being a fungus infection. And so in areas India, Bangladesh, equatorial Africa, reports of up to 56% of corneal ulcers being due to fungus infection. And so it's more frequent. You could draw a line here, and perhaps as you go further north, the likelihood of fungus infection is reducing. Clinical signs can be helpful. So this is a patient who was managed for herpes simplex keratitis, who had a secondary aspergillus, I think, infection from a dendritic ulcer. And so this is the primary site of infection and plaque and satellite lesions and the hypopion down the bottom. So clinical signs, solid hypopion. So anecdotally, you lie the patient on their side, and if the hypopion doesn't move around here, then that's a solid hypopion and more suggestive of fungal infection. Fluffy margins, satellite lesions, and a posterior corneal plaque. And if you do positive predictive values on this and summate them, so a raised lesion, so raised above the surface as opposed to being an ulcer, serrated margins, these are the positive predictive values. And if you've got all 3 of these, then it's very predictive of being a fungal infection. Next stage in diagnosis, and this is, again, the sequence of these things moves. And so for us, is this a fungal infection? First stop, confocal microscopy. This is not, the sensitivity and specificity is not perfect with this, but if you get the answer, and so this is a contact lens-associated filamentary fungus infection. This is a representative slide of what the hyphae look in the stroma, and this is the appearance in the confocal image. And you can see the filamentary structures here, the diffuse grey from the scatter of light from the inflammatory cells. And if you have your answer at this point, then you know you've got guided treatment for that. We then looked at OCT, and currently OCT has insufficient resolution to be able to identify hyphae within the stroma. People are working on algorithms to refine the image, so image analysis, to try and get things better, but the role at the moment is mainly to identify the depth of involvement, and if you can't see, just to see what's happening in the anterior segment of the eye. So it's not going to tell you with present techniques whether you've got filamentary fungus or not. Taking a corneal smear, this can be, again, rapid and helpful, but it requires the backup technology to do this. A lot of different methods for using different types of stains. So if you do nothing, and so this is just a gram stain, so it's not staining the hyphae, but it's showing them up in negative relief. So everything else stains except for the hyphae. So you can see the hyphae here in negative relief. With silver stain, you have a more specific stain for this, and also it demonstrates here, so this is actually yeast, and these are pseudohyphae. So in actively growing yeast, they can form in chains, which can look like hyphae. And these lactophenol cotton blue, this is a very low-tech method which is used in developing countries, and calciferol white, which is very popular in America because it will stain acanthamoeba cysts as well as filamentary fungus. And so these stains of a corneal scrape. We heard earlier the issue about sensitivity and specificity. You know, we would hope that if there's a fungus in the cornea, then DNA would be released and it would be 100% sensitive. So looking at the 18S ribosomal fragment, this is what that looks like, and in this area here there's a high degree of variability, and it will detect fungus with that. It could be, in theory, could be 1 hour to do this, but in practice it usually means sending the sample off to another laboratory, gets there 5 o'clock, done the next day, you get your results the day after that. So usually takes a couple of days, but in theory it could be done within an hour with an automated PCR equipment in your clinic or in your casualty. And so it still has a role, and I think that role needs to be developed and refined and improved. So it's there at the moment. So it's supportive evidence. So culturing it, and first point is if you want to culture it on anything, a sample, you don't know what it is, you put it on blood agar. So this is yeast, and this is aspergillus growing on blood agar. So if you don't have any of these specific media, fungus will grow on blood agar, but you just need to culture it for longer. And so your microbiologist mustn't chuck all the plates away after 2 days. They just need to do a slightly longer culture to pick that up. It grows better on dextrose agar, and this permits identification. Identification is being validated for this moldy Tuft, the system we used before, but it's in process. That's a method in process for getting rapid diagnosis of fungal infections. If you're not getting anywhere, cultures are negative, and so case here, 3 cultures were negative, and on the histology here, the filamentary fungus prefers the deep stroma, predecimase spread, and a superficial culture may miss it, even though there is fungus there. And so if you're not getting anywhere, you still think it's fungus, then either a formal biopsy, and if there's a plaque, you can do a posterior corneal biopsy, which is a bit like doing a sort of super trabeculectomy. You lift a flap onto the cornea, lift it up, take a little square of posterior stroma, and put the flap back down again. So it's a posterior corneal biopsy. Again, we talked not only about the regional differences in fungal infections, but also the importance of monitoring to look for changes. Fortunately, as Bruce said, we've not had any major changes in resistance profiles for bacteria, but for fungus infection, there has been major changes in the relative proportion of yeast and filamentary fungus as various environmental patient practice events have changed. So it's had an impact on the likelihood of risk factors and the profile of organisms that we isolate. And so this is a first run of a series. We looked at samples from Moorfields over this period of time. So lead author is sitting in the front row. So 39 isolates, 66% yeasts, 5.6-week diagnosis delay. And so people weren't really aware of the possibility of fungus, and it took a long time for the penny to drop. And 50% required PK. And this is the number of cases per year, and there was a suggestion that there was an increasing incidence of cases of fungal keratitis over the period of time. So what might be contributing to that? And so this is Renew, and this was a contact lens solution which has now been withdrawn in its current form. And this was associated with an epidemic of Fusarium keratitis in America and in Singapore with hundreds of cases. The exact mechanism was not identified why this happened. It may have been sort of killing the bacteria and allowing the fungus to grow. We don't really know. But it was an epidemic, and if you haven't got a monitoring process established, then you will miss this, or it'll take a long time to identify that things have changed. This is the big change we've had in the UK, was the change towards contact lens-associated filamentary fungal keratitis. So they're not using Renew. Renew was removed. We hoped it was all going to go away, but it didn't. And so there's still a background increase. So these are 4 cases of contact lens-associated filamentary fungal infection. They haven't been on tropical holidays, all acquired in the UK. And this very characteristic sort of superficial lesion on the cornea, not with deep invasion. If you left it, there would be deep invasion. And so this is a reanalysis of our data, and fungal keratitis increasing, that's green here, and statistically highly significant increased numbers of fungal isolates in the UK. So it's not just more people traveling to UK from overseas. So homegrown filamentary fungus has increased, and contact lenses have moved up onto the top of the risk factor list for filamentary fungus infection. The second event which has had an impact is Candida keratitis stroke endophthalmitis associated with endothelial keratoplasty. And so in 2016, there were 6 cases of fungal keratitis endophthalmitis associated with endothelial keratoplasty material. 5 of those 6 were Candida isolates, and this is what they look like. This is actually taken from a paper. And so these are these patch focal infiltrates on the posterior corneal surface, and that's the same patient after a period of time. Take out the sample, and this is Candida organisms beneath the graft. And so this is a dramatic change in the profile of what we're seeing. So why is this? And so this is data from the Eye Bank Association of America, and it's highlighting 2 important things. First of all, that there's been an increase in fungal infections associated with corneal transplant in America. There's also been a statistically, approaching significant increase in the proportion of patients who are having endothelial keratoplasties. And so these are the number of cases, 2007, missing out the intervening years, 2013, so 2 per 10,000 in 2007, increasing to 16 per 10,000 in 2013, predominantly associated with endothelial keratoplasty. So more endothelial keratoplasties being performed, but more isolates of Candida infection. Why is this? And so in our series, all the cases were associated with corneal material imported from the USA. And so a lot of eye banks in Europe, and we are combining data with Copenhagen and Germany, where they've had similar clusters of cases. And so all of the cases in those 3 centers in Europe have been associated with cold storage medium. You can, but rarely, get infection with organ culture. So neither of these products contains amphotericin. If they do contain amphotericin, it is put in by the eye bank as an addition. So as amphotericin B is added to this, it's not manufactured with amphotericin. And the difference is that all corneas are potentially contaminated with Candida. But in organ culture, usually 1 to 2 weeks before the tissue is released, the medium is sampled. And if the Candida is there, it's not sampling the rim, it's sampling the medium. If the Candida is there, the tissue is removed. It's not given to the patient. With cold storage, various different theories to why this happens, that the antibiotics may be suppressing the bacteria but allowing the fungus to grow, but demonstrated that it's definitely possible to get Candida contaminating the rim, but there's no sampling stage. And I think either they're going to have to start putting amphotericin into the medium, or find some way of identifying corneas which are a significant problem. So in 2016, 26,000 corneas were exported from the United States in cold storage. And so, sadly, this process happened, 2 or 3 cases happened, and then people only met in like the canteen saying, I've got one, well, yes, I've got one too. And then the German cases, we only knew about this because we heard them talking about it at a meeting. And so there's poor communication. And I think this is the age of big data. And I think in bacteriology and fungal disease, we really need to be getting our act together in talking different centers and pooling data much more quickly. These are the isolates, so still yeast more common, but the difference has changed. So what are we going to do to treat this? And these are the options that we have, so polyenes, azoles, and in yellow are the ones which are readily available, and natamycin is the only one which is commercially available. I understand it's not commercially available in Spain. Okay, and so natamycin, amphotericin in this group, voriconazole in this group, and these are your oral options, which is usually boils down now to voriconazole. So reasonably limited spectrum of agents that you can use. And so this, how do you tell which one to use? Well, you can use in vitro sensitivity, and so send them to the reference lab, they'll send a sample back and say whether it is sensitive or resistant, and you've got all the limitations on the MIC. What does MIC mean for bacteria? We don't really know, and we have even less idea what relevance of it is to fungus infection. So using these numbers, we have this rough idea that most will respond to amphotericin, but it doesn't take into account anything about bioavailability, pore penetration, those types of issues. And so other people have looked at this again, and so this is one way of approaching this. A better way of looking at this is randomized controlled studies. And randomized controlled studies to look at fungus infection is really going to be difficult in Europe because it's so rare. So all of this is reliant on where it's more common, and that usually boils down to India and Bangladesh, where they seem to be able to recruit 400 patients a year, some fantastic numbers of fungal infection, and 10 reasonable randomized controlled studies. Proviso, they're all from Asia. Majority of their samples are filamentary fungus. So It's not entirely a reflection of our practice in Europe, where 50% would be Candida infections. But that's the best we have to go on. And so based on that, we developed our guidelines. And so the conclusions from all these randomized controlled studies are here. And I'll just read them out. So chlorhexidine requires a concentrated dose. And so you can't use your off-the-shelf treatment for acanthamoeba, which is 0.02. You need to have the fortified chlorhexidine to be effective. Chlorhexidine is a bit better than natamycin. Natamycin is better than iconazole, and natamycin 5% is superior to voriconazole. So somebody in the audience may wish to put an application through to your health department to have access to natamycin. It's a relatively cheap product which is licensed, or could be licensed for that. Intrastromal injections can make things worse. It's no better than just topical treatment. I think there's an incentive. You've got to do everything. You put in drops, you inject the cornea, put it in the anterior chamber, have it orally, have it intravenously, just to get a lot of the antifungus there. But for small superficial lesions, you don't need it. And no benefit of oral over topical itraconazole. So you don't need, for small to fine central corneal lesions, you don't need oral treatment. You might if it's involving the sclera or anterior segment. And so suggested treatments, so lesions confined to the superficial cornea in the middle, like those patients with contact lenses. So we start with topical natamycin or chlorhexidine in the fortified concentration, hourly, day and night for 48 hours. Don't know why we have to do that. It just seems like a reasonable concentration and frequency to be using. And then reduce to 4 times a day until the ulcer is healed, and then carry on for a bit after that. If you start with one of these and you're not improving after 5 to 7 days, we add in the second one. And alternative to voriconazole is amphotericin. If you isolate a yeast, then definitely switch to amphotericin. Bigger lesions in the anterior chamber or sclera, we add oral voriconazole. So we don't use it for the isolated corneal ones. We use it if the spread into the anterior chamber or sclera gives good intraocular levels. We know that. But it is hepatotoxic. So you have to have blood tests before and during treatment. An alternative is itraconazole. Supplementary treatments. Intralesional voriconazole, there's poor data as to whether it has any effect on this, but it's reassuring to have a very high concentration. But injecting it into the stroma can cause inflammation and precipitate perforation. Intracameral, so injecting voriconazole into the eye, or intracameral amphotericin, again, limited to patients where there is suspected intraocular extension. I don't think it's needed if there's just corneal disease, and these are the representative doses. Management of inflammation, stop topical steroid. And I think this is any type of bacterial keratitis. Don't use topical steroid until you're sure what you're dealing with. If it is a fungus, stop it. And I think you have to put up with the inflammatory problems rather than potentiating the fungal growth. If there is bad inflammation that you need to do something, so the patient's had a corneal graft and you don't want the graft to melt, then topical cyclosporin at this concentration, that's one product which does that, or systemic cyclosporin, which can be effective over quite a short time in controlling inflammation. So use this rather than adding in topical steroid for that. If you have culture-proven disease, and so Candida, the spectrum for amphotericin B is probably better than voriconazole, and so if we get a positive culture, we switch to amphotericin. And these other agents here, if things are really going badly, speak to your infectious diseases consultant or microbiologist, and these are alternatives for Candida, posaconazole for fusarium, and definitely if there's potentially intraocular extension of Candida, in addition to amphotericin, consider fluconazole orally or topically with that. some evidence that there is some synergy between fluoroquinolones and amphotericin, so they may work together, and topical cyclosporin may also inhibit filamentary growth. It is a fungal secreted product. And so this is the Juan, who doesn't like algorithms, so here's an algorithm. So diagnosis. You made your diagnosis. Start with your empiric treatment. You've got to do something, so you're not going to wait for the results. And then superficial infection, deep stromal infection, awaiting the results, and then modify your treatment as necessary. And so here we go. Diagnosis, fungal keratitis. Start your empiric treatment. This is what we use on this side, topical natamycin. It doesn't penetrate well, so if there's a small epithelial defect here, we debride the epithelium back here every day or alternate days to facilitate penetration. Similarly, if it's under a LASIK flap, then it's not going to penetrate the LASIK flap, and you have to debride the epithelium. If no response in 5 to 7 days, add in a second agent, this fortified chlorhexidine, and these are pretty sensible alternatives. You don't have access to this voriconazole and amphotericin. And so in Spain, I think your primary choice would be voriconazole for these superficial infections, but perhaps try and obtain that. So this is what I mean by a superficial infection. Things are worse, so deep stromal infection with possible spread into the eye, then we start with topical natamycin, so you might use voriconazole and chlorhexidine, so dual therapy from the outset, and oral voriconazole. So this package here, consider intralesional voriconazole and intracameral voriconazole. And if the lesion is deteriorating rapidly over 2 days, then I think you need to invoke the power of cold steel, which is an excisional keratoplasty. This applies mainly to filamentary fungus. If it's deteriorating despite your best efforts, then an excisional keratoplasty to remove the infected tissue. So when you get the culture result, you modify it, and so there's a yeast. Top of the list is amphotericin. These other things are quite good here. And for filamentary fungus, these two. So a little bit of modification depending on your results. Excisional keratoplasty, so on the side here. How do we do it? The talks later on today. We try and get 2 millimeters of clearance, so into normal cornea. Remove anything else that you have to, the iris and lens if necessary. Do a peripheral iridectomy because of the high risk of inflammation causing corneal bombae. Cyclodialysis if you're doing a corneal scleral graft and you're taking out the angle. Inject voriconazole at the end of the procedure, not at the beginning, because you'll lose it all. So do the graft, get everything stable, and the last thing you do is put in some voriconazole. Use interrupted sutures, clearly, in case they start to melt. Intracameral TPA, tissue plasminogen activator. You might want to use that to get rid of a fibrin plug, but if the graft has crossed over onto the sclera, I've done this twice and got a secondary hemorrhage from this. So I wouldn't use this if your incision is involving any vascularized tissue. Recurrences, in our experience, is about 30%, so this is the corneal graft. Is it growing back again in the anterior chamber? And you can add on with, graft 1, graft 2, graft 3, until it's controlled. So just carry on until you've controlled it. These are my summary guidelines, finishing on time. Stop topical steroid and debride the ulcer if possible to facilitate the antifungal penetration into the lesion. First line, ours is topical natamycin. Yours would be topical voriconazole. Number 2, either chlorhexidine. If it's doing badly, add in chlorhexidine. Oral voriconazole at this dose. Monitor liver function with that. A significant proportion of patients can't tolerate it. Their liver function starts to deteriorate. And if the eye is really inflamed, then topical or oral cyclosporin. If you're doing corneal transplantation, then you may wish to add in cyclosporin orally. It's a safe, immunosuppression for managing this type of infection, and also consider doxycycline, large randomized study going on in India at the moment to evaluate the role of oral doxycycline to control inflammation and melting. 7 seconds overdue. Thank you.